Hello, everyone. My name is Satheesh Chonat. I'm a pediatric hematologist at Emory University and Children's Healthcare of Atlanta. I'm here to talk about the real-world experience for patients with paroxysmal nocturnal hemoglobinuria. These are my disclosures. Over the next few minutes, I'll be taking you all through a brief overview of paroxysmal nocturnal hemoglobinuria, henceforth called as PNH, with brief overview of data from the ASH 2021 meeting. We will discuss the value of this real-world data and also summarize some of the findings from the meeting from last year, and certainly discuss some of the take-home clinical pearls. So first of all, I would like to discuss some of the pathophysiology of paroxysmal nocturnal hemoglobinuria, which occurs secondary to an acquired or a somatic mutation in the PIGA gene. And this is essential for production of the GPI anchor protein, as seen in between the red cells and the CD55 and 59. So due to the lack of this anchor protein, patients with PNH have red blood cells with deficiency of the complement protective proteins, CD55 and 59, which are normally present on the red cell surface. So the incidence of PNH is estimated at about 1 to 2 cases per million worldwide. In the United States alone, there are about 5,000 to 6,000 cases, and about 450 new cases get diagnosed every year. It's important to note that these are data from the International PNH Registry, so it does present some limitations. The most common age group represented in this registry are between 30 and 59 years of age and from selected countries. And it's also important to note that children account for approximately 10% of patients with PNH. So what is the underlying mechanism in PNH? As shown here in the cartoon above, in healthy bone marrows, these stem cells make normal red blood cells and other blood cells. In bone marrow where there is a glycoprotein inositol or GPI deficiency due to the PIGA mutation, they're by itself not sufficient to expand and result in the production of abnormal blood cells, causing the clinical disease of PNH. There are several internal and external factors which drive this clonal expansion of PNH cells, as shown here. And of which these factors are aplastic anemia, which can co-occur in PNH, and autoimmunity. And some certain genetic factors and defective T cell regulation have been discussed. And these factors preferentially affect normal red stem cells, thereby offering a survival advantage of these mutated PNH stem cells. So all these factors result in the production of these GPI deficient blood cells of all cell lines, namely red cells, platelets, neutrophils, lymphocytes, among others. So the deficiency of this GPI anchor surface protein, CD55 and 59, on PNH red blood cells render them susceptible to complement-mediated hemolysis. So as shown here, these patients present with symptoms of intravascular hemolysis, with symptoms of anemia, and also dark urine, abdominal, chest pain, and several other symptoms. Now, the mechanisms underlying thrombosis in PNH remains unclear, but it is thought to be secondary to a combination of factors such as activation of platelets and coagulation factors, along with presence of thrombogenic microvesicles, which are released during the red cell breakdown. And it can certainly involve any veins in the body, but especially known for in the liver, vessels, lung, brain, skin, or limb. It's also important to note that the bone marrow failure as a third feature in PNH is not secondary to the PIGA mutation, but presence of PNH clones in aplastic anemia are suggestive of immune-mediated bone marrow failure, which may be clinically relevant, as some studies suggest that these patients are likely to respond better to immune suppressive therapy. Now, once PNH is diagnosed, it's important to classify them to one of the 3 major types of PNH in the development of a management plan, as shown here. But what I've not shown is the third type, which is called the subclinical PNH subtype, where there's no specific PNH therapy is required, but what is required is a regular and careful monitoring for a bone marrow failure and the PNH clone size in these patients. The two other major groups I mentioned here on the left is the aplastic anemia PNH. So in this, as mentioned earlier, the presence of the PNH clones in this aplastic anemia group may suggest a favorable response to immune suppressor therapy. In aplastic anemia PNH, treatment is directed towards the bone marrow failure. Immune suppressor therapy doesn't actually affect the PNH clone size, and complement inhibition is therefore used if there is large clone size and related hemolysis. Some patients and providers opt for an upfront bone marrow transplantation, especially if there is a related donor available, as it effectively transplantation reduces the PNH clone size. Complement inhibition is the current standard of care for the classical or hemolytic PNH, as shown on the right, along with the supportive therapy. But in all cases of thrombosis, it's important that anticoagulation should be promptly initiated. I've also listed some of the FDA-approved therapies for patients with PNH, and the several additional agents are actually currently in development. Now, since PNH is a rare condition, there has been an recent increasing interest in PNH and also several other complement-mediated disorders. Therefore, data presented at large medical conferences, such as the American Society of Hematology, or ASH, can get overlooked. American Society of Hematology annual meeting from 2021 and others that happens yearly is the largest gathering of clinical and basic science research focused on hematological disorders and malignancies. But what is the value of real-world data? It can provide insight into what happens in daily practice after they are studied within the clinical trial settings. And more importantly, in these data, the effectiveness rather than just the efficacy of such therapies can be evaluated. Therefore, the evidence is larger generalizability with reduced clinical biases that may be present in clinical trials. In the next few minutes, I will review some of the abstracts on the real-world data in PNH. As we may know, the fatigue is a common symptom associated with PNH in over 70% of patients in the International PNH Registry. The functional assessment of chronic illness therapy fatigue scale, otherwise called as FACIT fatigue, is a score system that ranges from 0 to 52. Higher scores indicate less fatigue in patients with PNH. For example, in patients with cancer, the FACIT fatigue clinically important difference is estimated to be an improvement of 3 to 5 points from baseline. But such disease-specific, clinically important difference scoring system for FACIT fatigue has not been estimated in patients with PNH. So in this abstract, the objective of the study was to determine this FACIT fatigue clinically important difference, or CID, for patients with PNH using distribution and anchor-based approaches and real-world data from the International PNH Registry. On this slide, the FACIT fatigue scores were assessed at baseline and at 6 months, 12, 24, and 36 months in over 400 patients. The results shown here are that the use of 5 points as the clinically important difference for FACIT fatigue score in individual patients with PNH is close to the range of the clinically important difference reported in other diseases such as cancer, which are about 3 to 5 points. The purple bar has shown here between 6 months and 36 months shows a difference of about 3 to 5 points, which is markedly smaller than the 10 points which were achieved in the long-term eculizumab treatment in the pivotal blinded phase 3 TRIUMPH study. This finding is obtained from a real-world data set with a large number of patients helps establish an important metric for assessment of the meaningful treatment response of patients with PNH. The next abstract was the long-term survival benefits of eculizumab. As we know, eculizumab is a monoclonal antibody that targets complement protein C5, and it was the first FDA-approved drug for PNH in 2007. The primary objective of this study was to describe the baseline characteristics and overall survival of a large international cohort of eculizumab-treated patients compared with the contemporaneous untreated cohort using data from the prospective observational International PNH Registry. They actually studied over 4,500 patients, and they define the patients with high disease activity as an LDH more than 1.5 times the upper limit of normal and a history of at least one of the following: fatigue, hemoglobinuria, abdominal pain, anemia, dyspnea, major adverse vascular events, dysphagia, or erectile dysfunction. They found that patients who were ever treated with eculizumab had LDH of more than 1.5 times the upper limit of normal, and fewer than 10% of PNH granulocyte clone or a history of bone marrow failure when compared with the never treated patients. So the hazard ratio for mortality in eculizumab treated patients compared to those who were never treated demonstrated a 52% increase in survival in the treated group. So as shown here in the table up, they looked at the hazard ratio for mortality in patients who were ever treated or never treated. More importantly, they also looked at the high disease activity. As shown here in the first row, patients who received eculizumab and with high disease activity at baseline did experience the largest reduction in mortality, with 54%, the relative survival benefit. However, as shown in the subsequent rows, the decreased mortality was also evident in those patients treated with eculizumab, even with or without the high disease activity at baseline. Moving on to the next abstract, looking at the real-world evidence of the changes in hemoglobin in patients who were treated with the complement C5 inhibitors. So we all know the Alexion 1210 PNH 301 study had found that the ravulizumab, which is a longer-acting C5 inhibitor administered every 8 weeks, is non-inferior to eculizumab administered every 2 weeks for all the efficacy endpoints. So the objective of this abstract was to look at the real-world evidence on changes in hemoglobin in patients treated with C5 inhibitors, both eculizumab and ravulizumab for PNH. So they wanted to describe the demographic findings or the differences, the healthcare utilization, and the clinical characteristics of these patients prior to the inhibitor therapy, and to examine changes in hemoglobin levels from baseline to 6 months after treatment initiation in this population of over 12 years, and they're using electronic medical record network. So as shown here on this chart, the top is for ravulizumab, the bottom one is for eculizumab. 58 patients were treated with ravulizumab and 124 patients were treated with eculizumab. But the hemoglobin results were available at baseline and 6 months in only about 50 and 32 ravulizumab patients and 110 and 81 eculizumab patients. And that's the only one which has been shown on the graph here. The mean baseline and 6 months, the baseline are in blues and the 6 months are in red. Hemoglobin values for these cohorts were 10.6 and 10.7 grams for both the cohorts. The analysis of hemoglobin values showed trends toward hemoglobin increase for both cohorts, ravulizumab and eculizumab, which were driven by the larger proportion of patients achieving more than 12 grams of hemoglobin. We also noticed that the hemoglobin stabilization at 6 months were observed in 94% of ravulizumab treated patients and 93% of eculizumab treated patients. So these real-world hemoglobin results suggest that despite C5 inhibitor treatment, as shown here, anemia was still persistent in some patients, possibly due to incomplete control of ongoing intravascular hemolysis, including some extravascular hemolysis seen in patients receiving C5 inhibitor therapy for PNH. The study did have some limitations, and authors reported on the abstract on addressing in future analysis. The last abstract I want to discuss on the real-world data is on thrombosis. We know that it's a leading cause of death in 67% of patients with PNH before the use of complement inhibitor therapy. The treatment with complement inhibitors is a strategy helping us with reducing up to 80% of thrombosis risk and improving survival. However, the high cost of these complement inhibitor therapies limits access in low and middle income countries, such as Mexico, where this study was conducted. The primary objective of this study was to analyze thrombosis-free survival and mortality in PNH patients receiving oral anticoagulation compared to historical controls. And they conducted the study over a 30-year period in patients with classical PNH. As shown here in the chart, it was performed in 44 patients 19 received oral anticoagulation, and they compared it to a historical 25 controls who did not receive anticoagulation. The study replicated the results previously reported by Hall et al., demonstrating that primary thromboprophylaxis is safe and effective in reducing the risk of thrombosis, as shown, and they did not notice any thrombosis in the group that had received anticoagulation. And they also noticed an improved global survival. So in low and middle income countries where access to complement inhibition is limited, the use of thromboprophylaxis could certainly abate thrombosis and should be taken into consideration in all patients. As shown here, there were a few deaths in both the groups, primarily from aplastic anemia and leukemia, suggesting that in spite of if the complement inhibition or thrombosis is addressed, the clonal progression could become the leading cause of death in these patients. With this, I'd like to take you through the last part of the slide, which is on the take-home messages. Hopefully, I've discussed that the fatigue clinical important reference score of 5 points shown in the abstract in PNH is close to the range of CIDs reported in other diseases. Certainly, this scale would be helpful for future studies. The survival benefits of patients treated with eculizumab, regardless of the high disease activity status at baseline, does improve the survival, but is also pronounced in patients even without high disease activity. In patients who are treated with eculizumab and or ravulizumab, the hemoglobin stabilization was observed in both these cohorts, but there appears to be a persistent anemia in some patients despite C5 inhibition in the prospective real-world data studies. And lastly, in low middle-income countries where access to complement inhibitors is limited, the use of thromboprophylaxis could reduce thrombosis-related mortality. Thank you.